So I thought it would be useful to demonstrate how we work the enhanced services into the year of care approach. And obviously there's been a review and a slight change in the Betsy DOAC enhanced service over the last year. And so I thought it would be useful to show how we've amended how we find the patients and how we've changed the templates to accommodate this, with a couple of references to the assurance framework in it. So the updated DOAC LES has changed a couple of things in terms of who it wants us to recall and how frequent it wants us to monitor some of our patients. And it's changed some of our annuals to 6 monthly and some of our 6 monthlies to annuals, including a few 3 monthly recalls. So if your patient has creatinine clearance between 30 and 60, or is over the age of 75, or has low body weight or fragility, we want 6 monthly, and then 3 monthly reviews if their creatinine clearance is between 15 and 30. And then it talks a little bit about the reviews in terms of how often we actually need to review the patient, and again similar criteria where it's saying that they might need a 6 monthly review or 3 monthly review depending on those factors as well. And then there's the new audit we need to complete as well, so I'll talk a little bit about how we can pull patients for that audit, which we've done for you if you want it. So if I go back to the searches, for claims, I guess we want to know how many patients we have on DOACs at the moment. We also need to make sure that we're claiming for any initiations in the past month. Now, I find it very hard to have a code that we're going to consistently use to show that we started them in primary care, and I think probably monthly we are just going to have to look to see whether they initiated in primary or secondary. We can see if they've had their bloods done, and I guess if they haven't done their bloods done by us, then there's a good chance they'll initiate a secondary, although that's not always the case. Obviously it's important to know if we have initiated. You get the £115 for initiating. If they've been started in hospital but we're still having to do the rest of the initiation workup because we can't see if it's been done, then we are still allowed to claim, although they're suggesting we should also be doing a DATIX report if that is the case. I suppose that the trouble we have sometimes is that whilst we might have the medication discharged quite quickly, we don't necessarily get the rest of the discharge paperwork, which I think makes it hard to know how much of that has been done with the patient, although we can at least use the WCCG and see if the bloods have been done and download those, I suppose. And then I've changed the criteria for how frequently people need bloods. So if you look at these, we're looking every year to make sure they've had full blood count, UNEs and LFTs. But we also know that some of them need them checking 6 monthly, so these are your groups where their creatinine clearance between 30 and 60, or they're over 75, or their weight is under 60, or they've been initiated in the last 6 months. So if the earliest initiation is last 6 months, we know we need their 6 months review. That's part of new criteria in the enhanced service too. And then if I open the 3 monthly search, this one's just looking for patients' creatinine clearance between 15 and 30. What these searches do as well is they look to see, are these people are they needing, say, 3 monthly or 6 monthly bloods, and have they been done? And if they haven't been done, that's where they come into this, they need their blood test doing. And there's a similar principle for the reviews. So this will look at patients needing reviews, and it's looking to see, are they simply the annual reviews, 6 monthly reviews, or 3 monthly reviews. Now these are patients whose reviews are outstanding at the moment, because obviously you'll remember I've got about 180 people in DOACs and 30 of them are due a review at the moment. And again, the review criteria, or when we should review them, has been adjusted according to the enhanced service, which for this group, 3 monthly is creatinine clearance between 15 and 30. For the 6 monthly group, it's the creatinine clearances between 30 and 60, or they're over 75, or they have a low weight, or they've just been started in the last 6 months. And then we pull them all into, hey, we've got 30 people who need a review at the moment out of our 180, which I guess makes sense. I think it's been amended to try and reduce the number of people needing 6 monthly reviews where they probably didn't need it. It's worth noting that I think there are a few that need 3 monthly, although not very many. We've thrown in a couple of other searches. So we did some quality improvement work with 50 medical students from Bangor as part of their project, looking at could we have a way of picking up patients who aren't on the correct dose of DOAC that runs in the background and constantly monitors that, and I'll show you how that works later. We also split the searches into patients initiated in the past year, looking at what they've had tested as part of the audit for the end of the year report, and those have been on it for longer than a year, so that we can pull together an overall audit that looks a little bit like this. And that's to try and marry up with the audit that they have given us, which wants to see something like that. So it wants to look at established patients, the total number prescribed, all the various indices there, and that's roughly equivalent. The one that's difficult is the ones, have we initiated them or not? Now, we've got codes that we do use, so DOAC initiated, and if the DOAC was actually issued the same day as the course was started, I suspect that's probably in primary care. But again, I think that's the one that needs cross-checking, because that's the one where there is quite significant payment if we initiate it or have to do the workup because the hospital didn't. And there isn't a specific code in the audit or a specific code in the enhanced service they recommend we use for that. So you may have had your own codes, we just don't know, and I think it's safer to say that's not one we can rely on, but it's indicative, and I think it's useful for perhaps the audit purposes anyway. And this is looking at, okay, who was established over a year, have we had their reviews done, 127 out of 142. We need to have a clear way of indicating who isn't responding to invites. DOACs initiated in the past 12 months. If they were initiated between 6 and 12 months ago, have they had their review and kidneys done within 6 months? Now, I know that the audit goes on a lot about doing this at the 31st of March. If you want to know what your figures are at a specific date, you simply, when you are running that audit, you'd click Run, and then in advanced options, you might choose the 31st of March 2024, and if you click Run on that, it'll run all the child searches, and that would give you exact same figures as if you were doing this audit based on these dates. And I guess it's useful to understand how I incorporate that into my monthly searches. So if you imagine the year of care searches, off-view searches showing all the processes outstanding for a population in the all group, and then it splits into month of birth for routine work. Now, enhanced service work, we don't try and pull that in by month of birth. We pull that in when it's due. And so what you can see is that there is a search for the patients who need to come in for a basic process for enhanced service. So the principle is always that we want basic processes done by healthcare assistants or healthcare support workers or phlebotomists with extra bits done at the time. We want all that process capture done first by them and then a review with a clinician, so we're not wasting anyone's time. So I know that when I go back to my DOAC searches and that there are blood tests due, which are that group there, I know that they will sit inside this group here, and also in that group is the MGUS Enhanced Service group, any of the shared care or near patient testing group, and any of our transgender patients who need a basic process. The principle is we're not having to run lots and lots of searches. I know that if you're for those enhanced services, they are in this group here. Now, further down my group of searches are the DOAC specific searches. Now, this is a group of searches. The first one, which is just queuing at the moment, but I'll come back to that, is the patients whose dose needs reviewing, and that's part of the 5th year Bangor University QI work with students. And then these are our patients whose reviews are due now. So this is from that search looking for 3-6 yearly reviews are due now. So out of 180, 28 are due now. Now, it points out that 16 of them will need blood tests first. So I know those 16 are going to be in this group up here to be invited in for blood tests. I suppose we could still do the review, although you might argue it's better to do the review when you've got everything to hand. So we've got this bunch where everything's ready and due, and I'll open up an example patient from this review group so you can see what I mean with the templates. So when we open this patient's record, it does have, the alert box is geared, so it will say to us, this person's 6-month review is needed. If you hover over that box, it'll tell you why this person needs a 6-month review. That's hidden from view in the video because I can't show any patient identifiable, and there's a name on that. But this patient is saying that DOAC was initiated in the past 6 months and their age is over 65. If we double click that box here, it'll open up the chronic disease template, which pulls in all the chronic disease things, including the DOAC review. And so you'll see for this patient that they need their AF annual review. I mean, realistically, there's not, I suppose it's entirely up to people what they want for the review. The main purpose, I guess, is to make sure they're well dose controlled. Are they anticoagulated? Have they had their child's risk done? And we have still included the EMIS calculators, although it will warn you that it's up to the clinician whether they want to use those or not, and then consider anticoagulation if 2 or more. And this person is already anticoagulated. It's saying that this person is for a 6-monthly review. It's got links to the DOAC LES here if people want to use those. So anything in blue in a template, you click on it, and you might click that they've had a review. There is, again, we've left the Cockcroft-Gault calculators in, but it is an off-label use, and clinicians have to decide whether they want to use the inbuilt calculator. For the review, it's pointing out, hey, you've got to make sure about adherence, any clots, any bleeding. So testing up to date, we know for this patient it is already, and we need to know they're aware of head injury advice. Have they got an alert card? It's usually in the box, but there are links to alert cards you can print off online if you want, and you might tick to say that that's been done. There's the information leaflets the enhanced service refers to, which again is part of the anything blue you can click, and that's the Betsy links, and you might want to tick that you've given the patient those. You don't necessarily have to do that, but it's just nice to show that you have done it. And then if it's applicable, it's suggesting we should have the planned stop date. This patient has atrial fibrillation, there is no planned stop date. We've put in the orbit score for the review. Now, we can build calculators, but they would need approval from the MHRA, and so we don't do that. But what we can highlight are the orbit factors you might want to consider. So for example, for this person who is a woman, it's pointing out that their eGFR is under 60, and you might want to consider scoring 1 for eGFR under 60. It points out their age is over 74, so you might want to score 1 for age. So it's an orbit score of at least 2. Now, if they had a low HB under 130, it would highlight that. If it was a man, because this is a female, is looking for HB under 120, and you can see the HB is 129. Hematocrit is 40.41 or 41%, and this doesn't flag up any significant bleeding codes in their records, otherwise it would show it here. There's no guarantee that's going to find everything, because we're not sure everybody codes bleeding as well as others. So again, there always has to be a little bit of clinician deciding whether it's reasonable to say this person has an orbit score of 2. And then the rest of the chronic disease template is still there. So you can see that it's suggesting this person probably should be coded with CKD. eGFR is 51. There is no ACR, so it will say lower down we should have ACR. Because they're on a DOAC and because they've got a chronic disease for the QI and healthy behaviours, it's saying, hey, we should be recording alcohol consumption. We need this person's blood pressure. Their bloods are up to date, so their 6-month unis for blood count LFTs are up to date, their lipids are up to date, their weight has been done. Really the only process outstanding there is alcohol for this patient. And of course ACR, because they've got CKD, and their blood pressure target is 140/90, so it's highlighting their blood pressure is not to target, it's 146/86 despite being done recently. And I'll go back to the searches for other examples. We touched on highlighting when the dose might not be right, so I'll pick a couple examples here. So you can see when we open this patient's record, it is pointing out, or it's suggesting that we review the dose of NOAC, there's a possible concern. So that's looking at the dose rules for the various NOACs, and I'll click OK on that. And you can see in the alert box, it is pointing out NOAC dose review, please. You can see that that does also flag up in the AF anticoagulation advisor, which I have left on, and if you hover, it'll tell you again the current anticoagulation dose differs from that expected. So it just it shows it works. I mean, you can, I would still leave that one on. If we were to double click on my dose review, please, which I'll do now, you can see it opens up the chronic disease template. Now, there's a few things here. It still has the assurance concern here, which is that this patient is over 65 and taking an antipsychotic, and it will flag that up for us, and that's coming back into QI by the sounds of it for this year's cycle. So that's all still in there from the previous QI project around prescribing safety, with links to the prescribing indicators. It opens up the chronic disease register, so you can see this patient has a stroke and needs a stroke review with links to advice on stroke reviews. It's pointing out that this patient's had a stroke, but they're not on a statin. Their cholesterol is greater than 4. They're on the AF register. So again, the CHADS VASC scoring, but it's pointing out that the edoxaban dose may need review. So there's two concerns here. One is the dose we should consider the dose changing if their weight's under 60 kilogram or the creatinine clearance under 50, and for this person it's the creatinine clearance under 50. It's also pointing out that we should perhaps consider apixaban or rivaroxaban if they have a high BMI or high weight, and yes, BMI is just over 40. And then back to the same DES review and orbit scores, mentions the kidney. If there's been an ACR done, it has suggested G3 and BA1 coding. Of course, we don't automatically code that. It's up to the clinician to decide whether that's appropriate, and it just gives you advice here if you want to see that, if you want to do that. It places this patient in a high risk group, and you'd have to go into the NICE criteria to see why for that. This person's due a dementia review, and it's pointing out the over 65 and on antipsychotics. We need their smoking, alcohol. The basic processes in the chronic disease register at the bottom. In the healthcare assistant template, they'd be at the top, because these are things I'd expect a healthcare assistant to do. We're a bit behind on lipids for this person. That's because their history of stroke. They should have that done. And you can see that they're up to date for the rest of their blood tests. And I'll go back to the searches. So in summary, we know that we've got a system for calling people in for basic processes. Assistants call them in for review when they're due. It wouldn't matter if we were in, say, May, for example. Clearly the numbers who are born in May are different, but those needing enhanced services stay the same. The numbers needing the reviews for the DOAC stay the same. And it's about having a robust recall system. Ideally, we should always be using the chronic disease monitoring recall code, if we can use these searches, 90E1, so that we can see who hasn't responded. And again, it means that we are able to chase up those that haven't responded to an invite and chase those who haven't responded to 2 invites. And we can stop there. I'll show a few more examples of perhaps things like people who do 3 monthly, so that people can see that. So for example, if somebody's due a 3 monthly review, and I'll open up one of these patients. So the first thing you see when you open this patient's record is the text saying that there's an enhanced service blood test due. So this is just trying to make sure that if we see them opportunistically, we're not missing out on that. And it'll point that out in the alert box. It says the blood tests are due, and it says what tests are due, which is for him full blood count, LFTs, U&Es, and they'll be in the it's in the hover box you can't see. and it's explained that they need 3 monthly review because their creatinine clearance is between 15 to 30. It's also pointed out they're high Ventolin users, and in the chronic disease that they have heart disease, heart failure, AF and CKD. Now if I open up the 3 monthly review, it opens up the chronic disease review register. So this is a complex one, it's a complex patient. They've inhalers on repeat but no diagnosis asthma COPD. Their SABA use is high, they're already on combination inhalers, more than 4 Ventolin in a year. They're on the heart disease register, and again it's a simplified review, but it's covering the basics with the links to NICE if you want that. Pointing out they're not on statin. Their heart failure, crucial that we know they need to monitor weight, we want good pulse control. Useful to have your New York Health Heart Association classification, although it's not essential. It's got links to heart failure care plan, NICE heart failure management. Pointing out they're not on an ACE, they are on the AF register, the CHADS risk, and it's saying that this person needs 3 monthly DOAC because they're 15 to 30, and then the same DOAC thing as before. And then same links to CKD advice and the basic healthcare processes at the bottom. So I know that person will be sat in my DOAC review due search here, but I know that because they need blood tests, they'll actually be sat in this search here, and they'll also be sat in this search here, waiting to be called in. So if anything, really, I mean, the important thing about this search is this is usually associated with enhanced service, which is linked with money, which is clearly an important issue. We just don't want to be missing this. And the same applies for the other enhanced services. So you can see, for example, it's the same process behind MGUS, the same process behind gender dysphoria. If I go to the all search, it would look for, we don't have anyone due a review for MGUS. We've got 2 people due a review for gender dysphoria. And again, if we were to open that up, and I will show that very quickly, actually I can't because the screen capture shows some patient identifiable information. But for these patients, it would open up the template to the gender dysphoria based on the enhanced service for that one. Just make sure that we're getting all the blood tests we should do and suggesting all the monitoring we should do for them.